the tool we use to measure plaque. This is how we quantify atherosclerosis with CT angiography. It's a non-invasive test, a little IV. We inject contrast into the coronary arteries, and we can see not only how tight a blockage is in the form of stenosis, but through making three-dimensional pictures, we can look at the number of lesions, we can look at the plaque volume, how much plaque is present in each segment of each coronary artery, and we can look at the overall coronary tree. So the combination of these things gives us the opportunity to quantify plaque and then follow patients over time with this tool. So the keto match, what we did is we had a baseline study of 100 participants. This is the intro slide, but funded by the Citizen Science Foundation. Thank you. Thank you all, especially to Dave and Nick and others who really put this together. So we know this issue, right? We have patients who adopt a carbohydrate-restricted keto diet for any reason, and their LDL may go up. Usually, the lipids get better in many patients if they're obese or have diabetes, but the lean patients tend to exhibit increases in LDL and sometimes extreme increases in LDL cholesterol. And it's been of great controversy whether this is dangerous or whether this is just another way of metabolizing energy in this ketogenic state. So we looked at these patients with high HDL, low triglycerides, and very high LDL cholesterol. We excluded patients who had genetic predisposition for high cholesterol, what we call familial hypercholesterolemia, and we excluded patients who didn't have a normal cholesterol before they got into the trial. So they had to have normal cholesterol, no abnormalities, go on a ketogenic diet, and then have this extreme response, and that's the population we studied. The aim of the study is to prospectively evaluate plaque progression over the course of 1 year in 100 metabolically healthy lean mass hyperresponders. Here's the baseline characteristics. We matched this against a population-based study. So we took a study called Miami Heart. They did CT angiographies, also read by me in my lab, in a population of patients, just of random sampling. So we have a population-based patients, asymptomatic people. We looked at their plaque, and we compared it to the plaque in our baseline characteristics of the lean mass hyperresponders. Now, lean mass hyperresponders are not familial hypercholesterolemia. FH, as we call it, is born with a high cholesterol and unrelated to their HDL and triglycerides, may be high, may be low, but they know they have cardiovascular risk because they've lived with high cholesterol and not in a metabolically healthy state for many, many years. Lean mass hyperresponders induced by diet and otherwise very healthy, metabolically healthy with a very good cholesterol, HDL above 80, and a very normal and low triglycerides. So a much different population. So we took these patients. Now we have 100 in the trial. We were only able to match 80 in the Miami Heart trial because of age restrictions in that study compared to the population that we studied. But now we're going to compare 80 patients of our lean mass hyperresponders to patients exactly the same age, gender, race, diabetes, hypertension, all the risk factors, except for LDL cholesterol, and we're going to see if they're different. Here's our baseline characteristics, and I think you can appreciate ages are identical, the ethnicity is identical, cholesterol is going to be different because of the lean mass hyperresponders. The average LDL was 272, right? Normal for an asymptomatic person is 130, and compare that to 123 in the patients in Miami Heart. Blood pressures were perfectly the same. C-reactive protein inflammation was the same. Hemoglobin A1C, their predisposition to diabetes was the same. So everything else matched up very nicely. So we looked at this population, and there were no differences, I'll show you in a moment, but no significant differences in plaque between these patients with an LDL, the Miami Heart controls, LDL of 123, and the ketogenic patients with an LDL of 273. So this is the comparison. This is the primary results of these 80 patients. The calcium score, quantified plaque in the coronary arteries, score of 0 in keto, score of 1 in the Miami Heart, so no difference, p-value not statistically significant. Total stenosis score, 0 on average. The median was 0 in the keto group. They had, on average, no significant plaque, and a score of 1, an average of 1 in the Miami Heart, no statistical difference. Total plaque score, this is where we're going to start getting into our total plaque quantification. On average, 0 in keto and 1 in the Miami Heart, no statistical difference. And how many segments were involved in the coronary tree? On average, 0 with keto and 1 with Miami Heart. None of these were statistically different, but you can see even keto kind of trended on the better side of that. Higher numbers are more plaque and more stenosis. Now we're going to do quantitative plaque, where we're going to get all plaque quantification, and that's being done right now, but at least at baseline, these groups looked very similar. Now we looked at the LDL versus the plaque score, so this is increasing LDL. These are the LDL values of the patients, and here's the plaque that we saw in the lean mass hyperresponders. There was no relationship. If there was a relationship, you would expect a line like this, where higher LDL was associated with more plaque, and we don't see that. Same thing with Miami Heart. The LDLs are lower, 123 instead of 272, but no direct relationship. So LDL didn't predict plaque in the coronary arteries. We then looked at total plaque score and LDL, just another analysis. Again, increasing LDL, increasing total plaque score, and again, no relationship in keto, no relationship in Miami Heart. So the LDL did not drive plaque in the keto diet. In other words, patients who had a more significant hyper-response, LDLs of 400, 500, 600 milligrams per deciliter, did not have more plaque. These patients had 0, the patients at the far extreme here. So no direct relationship between higher LDL induced by the ketogenic diet and plaque in the coronary arteries. I'm not going to go through the mechanism for the sake of time, but this goes back to a wonderful paper written by Nick Norwitz and Dave Feldman, published, talking about the potential energy model and why you may get an increase in LDL, a decrease in triglycerides, and an improvement in HDL, good cholesterol, when you're in a ketogenic state. I wanted to show you, not everybody with high LDL automatically develops heart disease, even in familial hypercholesterolemia. Remember, we said this is not FH. But even if you looked at a population of patients with FH, they had no plaque at all, calcium score of 0 in 6,000 patients born with high LDL, and 5,000 patients had some plaque present. So LDL by itself, not always a driving force. You need other factors probably that help drive this forward and give us increased cardiovascular risk. And when they didn't have coronary calcium, there was no increase in myocardial infarction. And if they didn't have coronary calcium, even if they had high LDL above 193 for life, they didn't have increased risk of having a heart attack, stroke, or cardiac death. So we looked back at the duration of high LDL in the population we studied in these 100 patients, and the mean duration was 4.7 years. This is at baseline, so at follow-up now, we're going to have 5.7 years, and we finished the follow-up scans. We're still analyzing them, but we're going to have 5.7 years duration of elevated LDL induced by ketogenic diet. And of course, our sample size, we'd have to admit, is modest, 100 patients, but adequate to answer the question about what we will see as plaque progresses. So we concluded that after a mean duration of 4.7 years, with a carbohydrate-restricted diet inducing high LDL, a median of 272 milligrams per deciliter, a metabolically healthy cohort, and that's going to be important. A metabolically healthy cohort of lean mass hyperresponders on a ketogenic diet did not have greater atherosclerotic burden than participants from a population-based cohort with similar risk profiles but markedly lower LDL cholesterol. Again, there was no correlation between LDL and plaque burden. So we did not see a direct relationship where the higher the induced LDL, the more atherosclerosis at baseline. We'll have a one-year follow-up to help look at this. So let me just finish up with just this last slide, and then we can open up for Q&A. But I think that this is supporting data in the context of good metabolic health, that high LDL cholesterol may pose less concern, especially when it's induced by ketogenic diet. I don't think it eliminates or diffuses the lipid hypothesis that in patients who have metabolic disorders, diabetes, metabolic syndrome, other coronary artery disease, that LDL shouldn't be reduced. LDL is a modifiable risk factor in the setting of metabolic disease. In the setting of good metabolic health, we did not see a predisposition, at least over 4.7 years, for more atherosclerosis than the general population. So poor metabolic health and or existing disease will still need treatment. So a metabolically healthy person, why they might have a low HDL. So HDL is our good cholesterol, and typically it's opposite of triglycerides. So triglycerides are usually the fats in our bloodstream. As triglycerides go up, the body processes with a couple different enzymes and produces or metabolizes HDL. So HDL goes down in the setting of high LDL or VLDL or triglycerides. So low HDL is of interest, but we don't fully understand why some people are walking around with very low HDLs. And we tried to treat this. We used niacin, a B vitamin. We've used fibrates. We've used other agents called CETP inhibitors. And no matter what we do for these patients who have very low HDL, we can't seem to improve their cardiovascular outcomes by at least changing it with therapies. Now, exercise, diet may have some impact, but I don't think we have the full answer on low HDL. But to be clear, just to not confuse this issue, we only studied patients who had high HDL in this study because that was a sign of good metabolic health. So HDL, good cholesterol, goes up, triglycerides are going down, and LDL in these patients are going significantly higher, and that's who we studied. What do I? Oh, very low HDL is below 40. I'm sorry. So the definition of low HDL is 40. So as we lower HDL below 4, as people are born with or have HDL below 40, that's considered abnormally low. And there are some people walking around with HDL, the good cholesterol that takes the plaque, that takes the cholesterol back into the liver for excretion. So there are people walking around with HDLs of 20, which is very, very low. And those people usually have disease. That's not metabolically healthy. And I would say, obviously, longer and larger is always better. But I think 5 years with an extreme LDL elevation, remember, these are not modest changes. These are LDLs on average of 272. This is very, very high. Normal for asymptomatic people is 130. This is more than double that on average. And we had people triple that and quadruple that. So I agree it would be great to have longer term follow-up, and we're talking about trying to do that and to have even longer follow-up in these patients to continue to see what happens over time. But I think 5 years is not insignificant. I think 5 years of a very high exposure is atherosclerosis can start to form. Triglycerides are very variable. So triglycerides do tend to go up and down related to carbohydrates in your diet and other things. So yeah, it's not like a perfect linear line, but overall, as you continue this journey, your LDL, your triglycerides should continue to drop, and your HDL should overall continue to go up. But yeah, it might not be a perfectly straight line. It's a problem I face. I'm a preventive cardiologist, so I see these patients in my practice. I became interested because I have patients like this. I have patients who come to see me who have very high LDLs, but they look great, they're thin, they have no other risk factors for heart disease. And should they be on lifelong statins? Should I tell them to quit the keto diet and go back to something more moderate because they're having this LDL increase? Or is this LDL increase okay? And the literature is pretty scarce, right? We don't have good data. So I was just trying to answer a clinical question, and I think we're starting to get those answers now. Again, thank you to the Citizen Science Foundation.